Hi, my name is Dr. Jessica Trevino Jones, and I will be giving you a talk today about breast cancer. So, on average, breast cancer is going to happen to 1 in 8 women, which means as a physician, especially if you're a resident physician and you're doing a continuity clinic, there is a huge chance that you're going to see a patient that is either have had treatment for breast cancer, is on treatment for breast cancer, or you will be the physician that will diagnose the breast cancer based on the screening mammography that you ordered. We're not sure why, but the incidence of breast cancer is increasing. In the 1970s, the incidence of breast cancer or the lifetime risk of breast cancer was 10%. However, in 2015, that went up to 12%. We've corrected for different socioeconomic factors, ethnicities, and so on, but all across the board, breast cancer diagnosis is increasing. But happily, the likelihood of being cured is also increasing, which is tremendous to know that we have made such a world of a difference in the treatment for breast cancer. So here's a schematic showing you from the SEER database that breast cancer is on the rise in women under the age of 40. So we're seeing breast cancer happen to younger and younger women. So here's a quick little history lesson. I think it's important for us to know where we came from to know where we're going to go. So in 1960, the mammogram was developed, and it took us some time to get together. I mean, in 1976 was the first recommendations for mammography, so it took a while for us to get organized. But in any case, the mammogram was developed not terribly long ago, about 60 years ago, and it took different clinical trials that happened in the 80s and 90s for us to get the recommendations that we have today for how to use it appropriately. So, between the 1990s and the early 2000s, data from these huge clinical trials looking at tens of thousands of women were released. And the recommendations were that everybody should get yearly mammograms, that we certainly need to start no later than the age of 55, and in 2012, there was a decision that we should probably start screening women at the age of 40. In 2015, we had some pretty remarkable data showing there is a pretty profound healthcare disparities among Black and Indigenous people of color. And in 2016, we had data from a breast MRI released. Now, breast MRIs are the newer player to the field for screening, and they have a lot of benefits to them as well as mammography in terms of screening, but they're very different and you don't order them for the same reason. Now, the reason that the clinical trial was done between 2006, 2010, 2000, watching that 10 years of data to give us those results in 2016 was because there was a concern that women with denser breasts were going to have more incidence of breast cancer, which is why we needed to look at breast MRIs. The clinical trial was negative, though. However, it did show a subset of women, which we now will coin the term higher risk, to benefit from breast MRI screening as well as mammograms. In 2018, recommendations have been released stating that all Black American women should get a risk assessment to determine if they are at higher risk of breast cancer starting at the age of 30. So, on the note of that, well, who's high risk women? Why are we getting recommendations saying in 2018 all Black women should be assessed to see if they are higher risk? Moreover, why did our 2016 clinical trial show us that breast MRIs benefited this higher risk group of women? Well, let's talk a little bit more about what is higher risk. So, what is a risk assessment and who does a breast cancer risk assessment? So, let's break down breast cancer, okay? So, we do not know everything about DNA. We know a lot about DNA. Okay, we know a lot about DNA. So we know that there are certain genes like BRCA and some other genes like PALB2 and so on that can cause breast cancer. And for those, we coined the term hereditary. However, there's still some DNA and some genes we just don't understand, but we know that cancer can run in someone's family. So we can do tests on groups of families and see, man, everybody in this family had breast cancer or it skipped a lot of different generations, and we may not know the name of the gene yet. So that's why we still have familial breast cancer category, where just having breast cancer in the family puts you at higher risk. So if you think about it, anywhere between 5 and 30%, I like to think of it between 15 and 30% though, are hereditary, or there's some component to your family history for getting breast cancer. But then what about the rest of the world? What about the rest of breast cancer cases? I mean, if you think about it, then that's only really a small chunk that can explain family history. A lot of the times, breast cancer is actually sporadic, and 70 to 80% of the cases, breast cancer is sporadic. So if we do identify a gene like BRCA, or we have different other genes that we're learning more about, we can actually coordinate interventions and we can still give a cure rate of 99%. But sporadic breast cancer is unique because in sporadic breast cancer, 2/3 of these women can be identified as high risk. So high-risk women qualify for additional services for early detection, which will lead to cure for breast cancer. And as this slide is saying, they're actually the same interventions that we would give our high-risk patients like BRCA, and we can still obtain a cure rate of 99%. And in addition to that, the interventions can prevent 50% of these cancers. So what does this mean? What that means is you can look at this pie chart and say, oh my gosh, out of sporadic breast cancer, I can prevent 50% of that. So while DNA plays a huge role in our ability to, or our inability to avoid cancer, right? There's still a big role for how to prevent breast cancer that happens in our sporadic breast cancer patients. So let's take a deeper dive then and kind of check out, okay, well, who's at risk? What about this group that's supposed to be high risk? Where are they? And how do I find them? So it's challenging, right? Because and these are a little bit older numbers, but the newer numbers aren't out yet. But the percent of new cases for breast cancer in women age 30 is about 1 in 200. And if you're in a woman in her 40s, it's about 1 in 68. 50s, 1 in 42. And here's another schematic that's looking at it, but they kind of break it down 20 to 34 and 35. You can see between 20 and in their 40s, it's a much wider mark on your x-axis to show the percent of cases versus just this little blip it here of 10 years between 55 and 65 where you get 24.1% of the new cases. So you can see that breast cancer is more common in older women, but it is not impossible for younger women to have breast cancer. So 1 in 68 and 60, 1 in 28, you can see that's a big difference. Now, how people get diagnosed with cancer is the same, right? You get a mammogram, you get a biopsy. But if we're looking at women who are at higher risk of breast cancer, what makes them higher risk? If we're not just looking at family history, what other features to this patient would we look at to determine high risk, right? Well, here are some of those features. Some relative risk that lead to breast cancer would include having a diagnosis of lobular carcinoma in situ or ductal carcinoma in situ. These premalignant conditions that are called benign breast neoplasms. They themselves are not cancer, but they themselves are atypical irregular cells. You can see here how the relative risk is on the upwards of 16 and 17, as well as hyperplasia with the tibia. If it's alone, it's 5, right? A relative risk of 5. But if you add a family history, yeah, this girl's mom or this woman's mom has had breast cancer, her relative risk increases to 18, which is just as high, is higher than these irregular cells, these non-invading cancerous cells. So you can see as well, there's different factors that can contribute to a woman's breast cancer that's under 2 but greater than 1, which means that they are significant, but you would really need them in spades, right? But having second degree relatives, they add up. Relative risk of 1.5. A woman, how much she drinks, how much she weighs, these are all contribute to her risk of breast cancer. And when she had children contributes to her risk of breast cancer. But I want to put into perspective the genetic mutations like BRCA, a very strong genetic predisposition to breast cancer. You can see the relative risk is 200. And that's the patients who have like a 60% lifetime chance of getting breast cancer, 60 to 70. Relative risks are going to add up. So let's put this into perspective. If a woman is 40, right? We saw in a couple slides ago that in her 40s, she's not like It's not the most common age for breast cancer, but if she drinks alcohol and if she's overweight and she had an early cycle, she's not menopausal yet, and let's say she hasn't had a baby, if you add up those risk factors, her lifetime risk of breast cancer is 10%. 10% is not, doesn't sound like it's that big of a number. That means she's got a 90% chance of not having cancer, right? But her peers have a 1.47% chance of having cancer. So if there is a 40-year-old woman who has a lump, out of all the 40-year-old women, whose lump is more likely to be breast cancer? It's the woman who has a higher risk. And so even though this is saying a 10% lifetime risk of breast cancer, the woman who has more risk factors is more likely to be diagnosed with a cancer for that lump. But look at her at the age of 40. 10% is still considered pretty low, right? A moment that she turns 50, happy birthday, she just turned 50 years old. If she was still drinking 2 drinks a day, or if she was still not at her ideal weight, she was overweight. Let's say you can't change when she started her cycles and she still doesn't have children. Magically, her number goes from 10% to 16%. And you can look at her peers where the average is supposed to be closer to 2.3. So if you think about it, 10 to 16 is a tremendous jump. It's exponential, right? It's a much higher slope than 1.4 to 2.3. Okay? So relative risks do add up for our patients. So let's summarize it again. If the normal risk of breast cancer is 12.8%, a woman is at higher risk if she's got dense breast tissue, very dense breast tissue, especially if she's has early periods, if she has later menopause, if she's had any exposure to estrogen products, especially after menopause, any history of a breast biopsy, a family history of breast or ovarian cancer, her weight contributes to her risk, and if she drinks more than 6 glasses of alcohol a week. Now, any number of these are weighted differently, as you saw on our previous slide, but the definition that we typically use for high risk is greater than 20%. So what can we change, right? Well, we can change weight. The NIH updated their website in 2017 stating and kind of showing all these cancers that are affiliated with weight, and breast cancer was listed among them. Now, alcohol intake as well are contributing factors for increasing a woman's risk of breast cancer. And that data was first released in the 90s. Like, this is not new. This is 30-year-old data. But a lot of women don't realize how much alcohol intake is tied to breast cancer risk. Diet is also very powerful in risk factors. It's not necessarily taken into consideration when we do a lot of our risk assessments, but in 2011, the scientific community were given information that prolonged nightly fasting can actually reduce a woman's risk of cancer, of breast cancer in particular. Exercise is also a very powerful risk reducing measure that even a 10-pound weight loss can decrease a woman's risk of breast cancer tremendously. And breast density. We've known that breast density has been a risk factor for breast cancer since the 90s. And it kind of spurred on the breast MRI clinical trials and so forth, which we'll get to how this data and this information has kind of matured through time. But none of this is new, but these are factors that we can change. We can change weight, we can change alcohol intake, we can change our diets, we can change exercise, and we can change breast density. So, an example of how do you even get those services, right? So I'm giving you this lecture because I give these services. I am part of the UT Health Houston, home of the McGovern Medical School, and happily have been able to open our first breast cancer prevention clinic where we're organizing this care to be able to determine, okay, well, who is high risk and who should get extra services. So this is just a little bit of a moment of saying, yay, we did this. But okay, back to the back to the talk. Stronger than cure, right? Preventing cancer before it starts is really important. Because if someone has cancer, you cure it, but we want to do more. I want to stop it before it even starts. So let's talk about breast MRIs then. Breast MRIs are shown to be the best form of imaging for a dense breast. And you can look at this picture here that compares mammography to MRI. And it's crisper, it's clearer. And this is the same breast. And you can see here what is fuzzy and very dark, may be hard to appreciate, but here in an MRI is better delineated. And research has shown that breast MRI will detect tumors at smaller than average size, smaller than what a mammogram would determine. And they did a study where they took two radiologists and they gave them each the same amount of scans, the same scans, women who had both a mammogram and a breast MRI. And they had them look at these scans, and the radiologists were unable to diagnose a breast cancer 22 point, the mammogram missed 22.6 times the cases of cancer. So there were 22 women who only knew they were diagnosed with breast cancer based on their MRI. So a concerning statistic is that of the 90% of women who actually qualify for breast MRI screening, um, they don't get them ordered. And that the women who do get them ordered, on average, so in that 10% of women who do get it ordered, about half of them still won't get it performed. And adherence is still a big issue. And there's a lot of different reasons why these numbers are so dismal. If we know that this product is so good, if we know that this service is so good, and if we know that we can detect cancer, and we know that this is the right thing to do for them, why can't we get these services to these women? There's a lot of different reasons on many different levels. And risk reducing medications. So there are medications that have been approved since 2000, in the early 2000s. Like, we're going on 20 years of having medicines that we know can reduce a woman's risk of breast cancer. Of the almost 8 million women that are projected to have to be at higher risk of breast cancer, only about 100,000 of them are getting medication that can actively reduce their risk of breast cancer. So that's about 1%. 99% of women who qualify for risk reducing medications do not get it prescribed, and they don't even know that they qualify for medication. And why is this? There's lots of different reasons. So here's a schematic that was released back in 2007. Again, these are getting to be kind of older pictures that have been published, but this is not new data. So even though the medication can decrease a woman's risk by 50% and maintain that for the rest of their lives, it's very hard to prescribe it. And it's hard because most providers don't feel comfortable giving it. The best possible care would be a physician who typically prescribes the medications that you see listed, tamoxifen and raloxifene. The medications, tamoxifen and raloxifene, are most often prescribed by oncologists. Oncologists treat patients who have cancer, or have had cancer. So in theory, high-risk women, if we're going to give them the best possible care with physicians that are trained in giving these medications that are not chemotherapy, it would be with an oncologist. And the reason why it's not prescribed by internists and family medicine doctors and gynecologists is that it's just they don't feel comfortable doing it. And of a survey that was performed in 2012, of the 40% of providers that said, yes, I actually calculated someone to see if they were high risk of breast cancer, only about 13% of them prescribed the medications. And there's lots of reasons. They didn't feel comfortable with the side effects. They didn't feel comfortable prescribing it in general. They thought that an oncologist should be the one to do it, or somebody who had more experience giving that medication. But you can lift your patient up by bringing her risk down. So it's pretty good food for thought. Now, Black American women are considered high risk. And why are they considered high risk? Well, why did somebody make that comment in 2018? We should be doing high risk assessments for Black women. Well, Black women on average are going to be diagnosed with a more advanced breast cancer than white women. And even though a white woman is more likely to develop cancer, Black women are more likely to die from their cancer. Even if it's the same size as a white woman, even if they're given the exact same medicine, at the end of the day, we are not sure why Black American women are more likely to die from their cancer. They've even looked at the genetic mutations on the tumor, and mutation per mutation, it still does not add up to Black American women, we don't know why they are more likely to die from their cancer. But we want to fight the odds for her. So let's talk about in situ disease. So in situ disease are irregular, atypical cancerous cells that actually haven't invaded the tissue. So they're not technically cancer. So benign breast disease, that would be considered lobular carcinoma in situ and ductal carcinoma in situ. And the only way that we can really translate in situ disease is by looking underneath the microscope. And you can see here these pictures that I was able to place of pink and purple. I will call them pink and purple, pink and purple colors, right? And you can see different cells and they're walled off. And so you're looking at instead of having a nice linear cell to cell border around some kind of gland, right? You're getting a bunch of ants in the middle, but you can kind of see that they all have walls. And normally this would just be one line of cells, but there's more. And that would be considered in situ disease. This is actually grade 1, a grade 1 ductal carcinoma in situ. Now, if you can appreciate as the slides move to the right, you can see that the ants that are marching, right, the little purple dots, the cancerous cells or the irregular cells, they get less organized. And grade 2, you can see here, they still kind of follow the pattern that would be around a gland, but they're just not as many walled off, and they're kind of invading each other, and they're just not as linear as you would see on the first slide. And if you look on the third slide, you can see there is like no organization whatsoever, but they're not invading. So these irregular cells really aren't following any kind of pattern. They're just layers of atypical cells that this, of course, is worrisome. At some point, are they going to figure out how to invade? It's hard to say. And the reason why I say it's hard to say is because I'm only looking at pink and purple. But we've had an overview. This is an overview of 4 different models that have been proven. They have shown that ductal carcinoma in situ can change into invasive ductal carcinoma based on either an independent lineage model where you have a normal duct and you have ductal carcinoma in situ, and that'll never turn into cancer. And then you have irregular cells that will turn into cancer. Or you have the convergent phenotype model where you get ductal carcinoma in situ and they're both of these certain cell origins, and both of them have the capability of turning into cancer. An evolutionary bottleneck model where maybe there were a couple irregular cells and then they had decided they were going to invade. And the multiclonal, which is to me very similar to evolutionary bottleneck, but it's multiple clones that escape. You can see here one irregular cell won a battle, and in multiclonal, there was multiple irregular cells that figured out how to invade. In any case, I can't tell which ones they are because underneath the microscope, all I see are pink and purple, right? So I'm not sure if this ductal carcinoma in situ is a multiclonal version or if there's evolutionary bottlenecks or what. I only see what is in this point of time, which are irregular cells that are grouped together, not invading, but they're just not normal. That's changing though, because we're starting to look at the DNA of the cells. And you can see here an example of looking at DNA. And underneath the microscope, like for what we saw on the last slide, you can look at a tumor size of ductal carcinoma in situ, these non-cancerous breast lesions, right? 1.6 centimeters, 1 centimeter. They're both having estrogen on top of them. They both are in that middle section of like irregularity. And they have a couple of these features present. Theoretically, you might look at the 63-year-old woman and say, oh my gosh, like hers is a little bit bigger. I bet hers is worse. But actually, if you looked at her DNA of her tumor, she has a score of 3 versus the other patient who had a score of 57. And the difference is, even though underneath the microscope, I can't tell. I can only see what is staining, what takes color. One patient only has a 10% risk of having any cancer, any local recurrence, versus the other patient, which has closer to a quarter, almost 25% risk of local recurrence. And the reason why is because we're able to measure CD8 cells and different T cells and TP53 and HER2, and not all DCIS is the same. And so by looking at DNA of tumors, of tumor cells, of all of that, we're able to understand it better. So it's no longer pink and purple. We're able to look at the actual DNA, which brings us to invasive disease. Now, invasive disease is special, and I'm going to focus a lot on not only some of this data that I think, some of this information I think is just important for you to know to be a good clinician, but I also want to focus on what's going to be testable. So, surgery is just not enough when it comes to treating breast cancer. In 1804, the first surgical treatment that used general anesthetic was done in Japan, and it was for a breast cancer case. And you can see here historically what looks to be an inflammatory breast cancer. So, breast cancer has been around long before we were drinking milk from cows that had growth hormone or something. Okay, so there's something to be said about just the inherent condition that women we have, just being a woman, that puts us at risk of breast cancer for the women in the audience. So I want you guys to look at this tumor size and this tumor scale. So look at the very little pinprick in the middle. That is the tiniest tumor that we can identify, which is less than 0.1 centimeters. And we know that at that size, a tumor is too small for metastasis to occur. Now, if you go a couple circles out, what you'll see is between 0.1 and 0.8 centimeters, still less than a centimeter though. That's the first time that you can detect a tumor on a mammogram or MRI, and metastasis is possible. Now, I'm not saying that there's going to be a ton of tumors in a liver or a ton of tumors in a lung. What I'm saying is that even though there's a breast cancer that's less than a centimeter, there still may be cells in the bloodstream that have the potential to cause metastasis. You can see as you go down, as the tumor gets bigger, 1 centimeter, 1.3, 1.6, that, this is the mostly when women can feel their tumors, or men, when a patient can feel their tumor. Anything greater than 2 centimeters is the median size for clinical detection. So even if a woman was to remove her breast for a tumor that is less than a centimeter, which feels very extreme, right? Like it's so tiny of a tumor. It's important for us to know that there still may be cells floating in the bloodstream, even when it's that small. But genetic changes are guiding us, because even though we know inherently that surgery alone is not always going to be able to cure it, even though we know chemotherapy may not always cure it and radiation may not always cure it, we're able to now see, oh my gosh, what else can we do by looking at the DNA of these tumors? So we were getting smarter, okay? So we learned, and you could see back in the 1800s doing surgery on patients in Japan, that surgery didn't work. As we've gotten smarter, we've added chemotherapy. It doesn't always work. As time went on, we added radiation. It helped, but it didn't always work. So we started looking at all the different gene mutations, all the different errors that can happen on breast cells. And then we looked at the women where, despite giving them everything, when their cancer came back. And we may have noticed, okay, well, this woman, her cancer came back even though we did everything and it had XYZ. And this woman, it came back and it had, yellow and pink. And then this woman, it came back and we noticed it had these genes and pink. And so we were able to say, okay, well, this is maybe making a little bit more sense, because her tumor came back, but it's mostly, what we're able to say is, hey, most tumors that come back have this gene. So how is that clinically relevant? Like, how were we able to use that to treat better? It's one thing to say, oh, great, I'm so smart, I figured out that this is the right gene, but how do you apply that clinically? So this is what we did to apply it clinically. First, we started with our algorithm of, you get a screening mammogram, it's irregular, you diagnose breast cancer. We allowed for patients to go to surgery. And then at time of surgery, instead of just looking underneath the microscope, which is pink and purple, we were looking at the DNA. And we were able to see, okay, how many of those yellow DNA, yellow do we have on this tumor? And we were able to get a score. And the higher the score, the more we knew, okay, this woman, it's more likely to come back. It's probably because there's cancer cells in the bloodstream or for whatever reason, that woman benefits from chemotherapy. And we were able to tailor our therapies based on DNA of tumor types. And then, of course, radiation if it's indicated. And in this way, right, we're able to improve our risk. We can see maybe not everybody needs chemo. If you don't have all these gene mutations, maybe you don't need the chemotherapy. It's not going to help you. So we're getting better at curing cancer because we're getting better at understanding it. And in 2020, right now, we still need to know about aromatase inhibitors and selective estrogen reuptake modulators, but it's getting even better. We're doing dual therapies now. So that is early stage breast cancer. And we were able to determine, okay, by looking at the genes and looking to say, okay, which genes are more likely to have cancer come back, we were able to say, okay, you benefit from chemo. But what about women who have really big cancers? And you're like, whoa, this is a big cancer. I already know that you're at risk of getting cancer again because this is just, it just looks like it's bad, right? So when you think about cancer that you're worried is going to come back, you usually think about later stage cancer. And so what we used to do was we used to just do surgery and then chemo and then radiation, and then we would give medicine and we would start surveillance. But now we're shifting gears and we're starting to give chemotherapy more before surgery. And why are we doing that? Well, the reason why we're doing it is for the same reason a few slides ago I showed you, okay, pink and purple, but what did the DNA show? Underneath the microscope, I can see, okay, well, how did that tumor do with the chemotherapy? Did it kill it all? Because that's great, because that would be the thought, right? If a tumor is about 1 billion cells, then if my chemotherapy killed 1 billion cells, if it got rid of that entire tumor before surgery, then any microscopic cells that are in the bloodstream, I feel pretty good. It probably killed microscopic cells if it was able to kill 1 billion. So that's very helpful for me. And what that means is I can go to radiation and I can give anti-estrogen therapy if it's needed, and I feel even better about cure because I feel better knowing, hey, that chemo, hey, if it worked on the big thing, on that big Goomba, it's probably going to work on small ones. Okay, well, what about in the other scenario? What if it didn't work? What if, even if there's only 4 cells? That's a problem. Why didn't it kill it? It should have killed everything because that's the goal of chemotherapy. So there's 2 reasons it may not have killed those cells. The first reason is, well, did I not give enough chemotherapy? Well, I can't give too much chemotherapy because you get a lot of bad side effects, and there's only so many doses you can give before you get those side effects. So I hesitate to give more or less. But the worst case scenario is, well, what if it would never have mattered if I gave gallons of that medicine to that patient? Those cells were always going to be resistant. And in that case, I worry. If I couldn't kill even 4 cells underneath a microscope, what if one of those cells is in the bloodstream? What if that's one of the cells that sneaks and gets into a lung or hides in a liver and then later grows? Well, the important thing is I need to know that. I need to know if the chemo didn't work, because if it didn't work, then I have a new game plan and I can kill 2 birds with 1 stone. And after surgery and after radiation, I can give even more medicine and a different type of medicine. So I can, 1, give more medicine, and 2, give medicine that the tumor cells haven't seen and have a higher chance of cure. So we're getting even better and better at curing even later stage cancers because now we know, hey, okay, I'm having an idea that this didn't work. It's okay. I have options now. And so I just want to highlight here that, we need to know about aromatase inhibitors and SERMs and SERDs, and we need to be aware of their mechanism of actions and how to use them appropriately. If 1 in 8 women are going to have breast cancer, then we're going to see women on these medications, but we're also going to see women on more therapies such as abemaciclib because in 2020, new data was released that showed a benefit to including it. So um, while any learner watching this video may be preparing for boards, may think to themselves, okay, I'm going to learn this mechanism of action. You should be mindful that, in 10 years when you have to do your recertification, it's going to be like different again because we're getting better and better. So we're improving our ability to kill microscopic disease. So, final thoughts on breast cancer. Genetics play a big role in breast cancer. We've only been able to identify, as we talked about in the beginning slides, about 15 to 30% of genes. But even back on the Egyptian pyramids in 3000 BC, there's records on the pyramid of mastectomies where breast had been removed because women were identified to have tumors. And it was found on the Edwin Smith Egyptian papyrus. So there's still a lot we don't know, but we know women are at risk of breast cancer. And so, who qualifies for extra services? Get your mammogram. A woman doesn't need an order to get a screening mammogram. If there's a family history, genetic testing may be needed. And if you know somebody who's high risk, ask for a high risk breast assessment because we can't change our genetics, but we can change our lifestyle. And in doing so, we can improve our cure and we can stop history from repeating itself. So, on that note, thank you for your attention. And I hope you were able to learn something today about high risk women. Thank you. Bye bye.